All right, so I'm going to give you a bit of a brief discussion on lifestyle. I'm glad Rob showed you those slides because I haven't included them here. I'm mainly talking about treatment. And I'll hope to leave some time for discussion. So as we noted before, and you've seen this slide before, the obesity will significantly, in fact, I really liked Rob's terminology. It's probably better than saying obesity causes PCOS. It's probably better to say obesity unveils underlying propensity to PCOS. It's exactly the same as diabetes. If you're at risk of diabetes and you become overweight or sedentary, it unveils your risk of diabetes. So these girls, especially in your populations, but also very much in Indigenous Australians and other high-risk groups, that increased weight increases the androgens and increases the insulin. So why do we have to worry about weight? This is actually more in the context of our patient population, not just in PCOS. So we know that if we start with adverse lifestyle and excess weight, we have increased risk of unveiling PCOS and increased risk of infertility independently, which is obviously exacerbated if you have PCOS. Women are therefore going into pregnancy with a higher preconception weight, and between 25 to 50% now of women going into pregnancy enter pregnancy at an excess weight. The mother's weight at conception is now a key predictor of the child metabolic health and child weight at the age of 8. During pregnancy, and we just published this, I'll show you the data, around 50 to 60% of women will gain more than gestational weight gain recommendations. The classic myth of eating for two, the mother-in-law who comes over for the woman's confinement in pregnancy and feeds her ghee. Yes, that happens in Australia too. And so what we're seeing now is much more excess gestational weight gain and real problems with sedentary, complete lack of physical activity during pregnancy. Then we have women who have more postpartum weight retention. And just as Rob's presented there about the impact of weight, for example, if you have women who have gestational diabetes and they return to their preconception weight, in the healthy weight range, their risk of type 2 diabetes is not increased. So it's only a small amount of weight we're talking about. So, you know, if you're obstetricians and gynecologists, your big chance is to make sure that women know how important it is if they've had GDM to get those extra couple of kilos off and get back to their preconception or into the healthy weight range, because you'll have a dramatic impact on their GDM risk. And your conversion, because we have a large study at the moment in India, Sri Lanka and Bangladesh, and the conversion rate from GDM to type 2 diabetes postpartum in your population is positively scary and so much higher than the rest of the world. So one of the reasons that we're doing these large-scale prevention trials, and that's actually 2,000 women, the reason we're doing them in India, Sri Lanka and Bangladesh is the sample sizes we need to show benefit in your country are so much smaller because of the conversion rates. So postpartum weight retention, really important. And then obviously ongoing weight gain. You've got problems with epigenetic impacts in pregnancy, and then the obesity and health implications longer term. So your role is at every step of this diagram, and mainly about prevention. You can have a role in prevention when you diagnose these women, when you're treating them, when they're coming into conception, advising them not to gain weight during pregnancy, advising them to get back to their postpartum weight retention, avoiding postpartum weight retention. So why do we need to worry about weight in PCOS? We know that it's just bad for them overall. So in increasing their insulin and their androgens, worsening their metabolic profile, we know it significantly worsens psychological function, at least in Caucasian populations where they are worried about excess weight. It reduces the success of assisted reproductive technology, and it increases the ovulatory dysfunction, and there's some really sad, perhaps concerning, but good quality data that's come out of the Robertson Institute, where Rob is, about the impact of obesity on the oocyte quality. So for all of these reasons, it's pretty clear we need to do something about it. And I just remind you about the most important feature for women. This is internationally, but around the excess weight. So the guidelines recommend that in PCOS lifestyle is first line. These women, and this is a longitudinal study over a significant period of time, we've shown that women with PCOS tend to have an increased caloric intake. They often eat a healthier diet because they're conscious, but they eat more. They're more sedentary, and they have an increased rate of weight gain, and as I mentioned, that seems to change at about puberty, and so they have a higher excess weight. When we're doing the assessment of weight, at least in Western countries where excess weight is culturally very challenging, we have to be very careful about the way we assess weight respectfully, because of the problems of eating disorders and shame and concern that women have raised about it. But we do recommend it does need to be assessed at a minimum of 6 to 12 monthly. Again, if you're monitoring it, you're more likely to get prevention. Be aware of the mood and disordered eating that can occur in this condition before you counsel them about weight loss. Monitor and support them with achievable goals. And I know I'm going to say it 20 times before the end of the meeting, but focus on prevention of weight gain. So if you're going to use lifestyle, what should we be doing? So healthy lifestyle behaviours, being a bit more active, eating more fruit and vegetables, eating less high-fat, high-sugar foods. There is no rocket science. You do not need a dietitian to tell your patients that. It's the Indian version of the healthy food pyramid. In other words, just more good healthy food and less processed food. So healthy lifestyle behaviours in all those with PCOS should be there to prevent weight gain. If you have excess weight, then the best way to address it is with multi-components, so including diet, exercise and behavioural strategies should be recommended. And it's important that you don't set them up to fail. As I said, 1 in 1,500 women only will go from being obese to normal weight in a 5-year period. And that's in the normal population, not in PCOS. So if you set a 5% goal for weight loss, you get a dramatic change in insulin resistance when women start to lose weight. And I mean quite dramatic, which is why a small goal can give you a substantive benefit in terms of ovulation, improving ovulation and other outcomes. So if you give someone a 5% of their body weight goal, often they will be more likely to achieve it than just telling them to lose weight or telling them to go into the healthy weight range, which is usually not effective. And using the SMART goals, so they get specific goals, which might be about weight, it might be about specific other goals they've got, that it is achievable, realistic and timely, they're more likely to be effective. So, what diet? As I think I've alluded to, basically women can choose the appropriate diet they wish as long as it's healthy and balanced. There is no one low GI, high GI, low protein, high protein. Everything that's out there that's advocated is simply a fad, and there is no evidence in the general population or indeed in PCOS that one is better than the other. So it's really general healthy eating principles, but no one makes any money out of telling women that. But that is actually what the evidence shows. The bottom line is if you want to lose weight, you need an energy deficit, which is big. So we're talking 500 to 750 kilocalories a day. Now that's a very significant decrement in caloric intake, and most people will maintain that for around 3 months and lose weight in that time. The reality is most will regain, and the only way not to regain is to increase your physical activity or permanently keep your caloric intake lower, because we now know that we're set up to fail in that once you've had a significant excess weight, if you lose weight, you become metabolically more efficient. And it's been shown that longer term, the only way to maintain weight and prevent weight regain if you've lost weight from obesity is actually to be much more active than the general population, and that's generally not what we see happens. So once these women are obese, we have a very, very difficult time treating them and maintaining it. So again, it comes back to that prevention message. There is no evidence, as I said, for specific diets. You really need to tailor it to women. And I remember the last meeting in India, which wasn't that long ago, we had a session on lifestyle, and you had an Indian dietitian on the stage. And it was fantastic. You had all these world experts, and you had a local dietitian, and all the questions were for the dietitian, but they were for the dietitian, and they were mainly from the audience about how they would change their diet. You know, what oil should I use? What, roti, chapati, all the questions they had about their diet, none of which I could have answered. And the important thing is that it clearly needs to be culturally appropriate and information for your population. But the basics are very simple. What about exercise? So, and I'm going to temper this a little bit. This is the general recommendations, but in our research and others around the Southeast Asian population, physical activity and exercise is not highly regarded. In fact, the concept of exercise is definitely not something that's high on the agenda, especially not in pregnancy. Whereas activities of daily living and doing things with the family, and often dancing, is something that people will consider. So it's about how you tailor it and send the message. So if you want to just prevent weight gain, you do need to do a fair bit of physical activity, less time if it's intensive, or it's around 150 minutes a week. If you do activity, it needs to be in at least 10-minute bouts. So this is often useful for women to say it's not really activity unless you can do something for 10 minutes. So doing something that's very minor around the house, walking around the house for a few minutes is not going to do anything. If you're going to do something, do at least 10 minutes or at least 1,000 steps. And that's actually usually something women can do, and if they at least start doing that, then they can build it up. If you want to get to weight loss through exercise, you need a lot more. And you'll note that this is actually pretty intensive. So again, we need to keep it around prevention of any further weight gain. It's worth emphasising to women that their physical activity does include their leisure time. Any sort of transport, any occupational work is reasonable, but again, try and make it in 10-minute bouts. You can see that if we were going to rely on exercise at a population level for the treatment of obesity, it just would not be feasible. The amount of time required for physical activity here is quite substantive, which is why the mainstay of weight loss is primarily diet. So, again, prevention of weight gain, healthy lifestyle, then get very modest goals for treating excess weight. You do need to be proactive about prevention of weight regain. In Rick LeGros' trial, actually he used lifestyle and anti-obesity drugs, got around 7 kilos of weight loss in women and had good outcomes, but they got pregnant, and in pregnancy they all had a very significant rebound weight gain. And so there's evidence that we really need to keep doing something. But as much as possible with exercise, at least if you can reduce sedentary time and activities of daily living and get them to start doing 10-minute bouts, which is usually feasible. So just to touch on a few reasons why these are relevant. So we know at a BMI of above about 29, there's an impact on pregnancy, and for about 4% lower rate of pregnancy for every 1 unit of BMI. So I actually use a diagram like this on my desk in the office to talk to women about their chances of pregnancy. We're usually not talking about getting them back to a BMI of 25. We're talking about goals of 5% or goals of these sorts of levels. Now this is white data. It may be different for Southeast Asian women. I don't know what the specific details are. This is our recent publication from JAMA in about 1.4 million pregnancies from around the world, and basically showing that it didn't really matter where you were. Over half of women put on more weight than is recommended and healthy during pregnancy. Interestingly, quite a few women put on less than is recommended, so only 1/4 of women actually put on the recommended amount of weight gain in pregnancy. The way you work that out is you start with their BMI, and based on their BMI, you get a recommended amount of weight during pregnancy. Even obese women, so if you have an obese woman who becomes pregnant, they need to put on at least 5 kilos, because if they don't, they end up with a hormonal environment in utero which actually has adverse outcomes for the pregnancy. So no matter what your starting BMI, there needs to be at least some weight gain over the pregnancy. So in terms of the lifestyle for improving reproductive outcomes, which I presume is of interest to this population, we know there's several studies now. There's Rick LeGros' study in 2015 where they trialled the use of oral contraceptive pills being used briefly ovulation induction, and they also used lifestyle modification with meal replacements and weight loss. As I mentioned, they got a 7% weight loss, which is quite significant. And after the intervention, they were then given ovulation induction with clomiphene citrate for 4 cycles, and they looked at pregnancy visits right through until delivery. Basically, if you had lifestyle intervention, you had improved ovulation with clomiphene citrate, but in pregnancy, as I mentioned, they had a rebound weight gain. So highlighting that you can, this is a fairly intensive intervention, but you can get weight loss and you can get better ART outcomes. But the other thing is that what does happen is when you have delayed fertility therapy with preconception weight loss, there was a comparison over immediate therapy in obese women with PCOS, and what Rick showed in that study was that there was a benefit of improved ovulation and live birth weight when you had delayed therapy with clomiphene citrate if you used lifestyle modification first, versus if you just went straight to clomiphene citrate. Then there was a more recent study in 2016. This was a large-scale RCT in obese infertility in WHO class 1 and 2 and ovulation. It compared 6 months of lifestyle and 18 months of ovulation induction, or just straightforward ovulation induction with 24 months of therapy. Around 600 women, and with the lifestyle they achieved a good weight loss. The live birth rate in the lifestyle group was lower at 27%, this is with ovulation induction, versus 35% in the non-lifestyle treatment. But what they did find is in those first 6 months before ovulation induction, the lifestyle group, the natural conception rate was higher. So a lot of the women who would have conceived before they went on to ovulation induction. And if you actually exclude the non-completers in that study and take that into account, the live birth rate was similar. So essentially, Rick has written about this in several papers since, highlighting that the effect of obesity treatment on female reproduction perhaps doesn't give us the benefits we might want. But the bottom line is there are benefits that appear to be in place at the moment with more natural conception, and obviously there will be other health benefits, but we don't know who to intervene with and what dose. Do they make no difference in the morbidly obese? Is it only the moderately overweight? How much lifestyle, how intense, how best to do that, when to do it, and do we need a period of stability of weight before they get pregnant? So there are still lots of questions in this area. Just to highlight, and this is not in PCOS, this is data from our paper in BMJ recently, that there is now good evidence that if you intervene with lifestyle during pregnancy, and this is from individual data, patient data meta-analysis, so we've collected all of the individual trial data from a large number of RCTs and looked at what happens when you use lifestyle in pregnancy. You can easily, with very simple interventions, including apps and very low intensity, you can prevent excess gestational weight gain, and that in turn reduces caesarean section and prevented gestational diabetes. And there was also some evidence of improved preterm birth with dietary interventions. So this study, we're just about to upgrade this because there's 35 randomised controlled trials in the WHO database that we're now working with, but we've just got funding to increase that to the entirety of 105 randomised controlled trials in pregnancy. We do not need any more randomised controlled trials in pregnancy to show us that very small interventions can prevent excess gestational weight gain and have health benefits. We just need to work out how to put it into practice, and that's really the most important thing. I might just very briefly touch on this because Chandrika raised this as well. We don't have data about lifestyle and long-term health benefits in PCOS, but we do have it in other populations who are at high risk. So this is the Diabetes Prevention Program published in 2002 in many thousand non-diabetic individuals who are at high risk for diabetes, and basically looking at intervention with lifestyle, with metformin or with placebo, and what actually happened in terms of their outcomes. In this study, there was a dramatic decrease in diabetes incidence at 4 years with the intensive lifestyle, and even a 25% reduction by 15 years with that concept of metabolic conditioning that was mentioned before. The important things were decreased sedentary time, just reducing fat and saturated fat and high fibre. It was a very cost-effective intervention, and for every kilogram of weight loss, there was a significant 16% reduction in future diabetes incidence. That's a powerful message to tell your patients. If they have a family history of diabetes and you can say every kilo you lose, you can reduce your risk of diabetes by 16%, is actually quite powerful. And just very quickly to say that once people are obese, we probably have very little option but to use medical therapy. You probably can't see this, I'm sorry, it's small, but this is the GWAS, or the Genome-Wide Association Study for Obesity. And I remember being in the audience when this was first presented by Stephen Riley, and he did this beautiful talk where he talked about the monogenetic abnormalities of obesity and what we've learned with individual gene abnormalities. Then he went on to show us the GWAS, and he started by saying how many people in the audience think that endocrine causes are a significant contributor to obesity. And almost everyone, because they're all endocrinologists, put up their hand. And then he puts this up, and this here is the GWAS genes related to endocrine abnormalities. Do people know what this huge GWAS band here might be in terms of obesity risk? Any ideas? It's the neurobehavioural genes. So the genes that relate to self-discipline, self-regulation, behavioural modification. If you have genes that allow you to self-regulate, you're more likely to study, go on and succeed in life, have a high-powered job, and as it turns out, control your weight. If you have genes and neurobehavioural genes that actually don't allow you to do those things, you're more likely to become obese. And then once you're obese, we're asking you to do all of these behavioural modifications and lifestyle change, which is why we need to give people a much more reasonable goal and look at prevention rather than treatment. And it's because of these neurobehavioural genes that treatment of obesity is so difficult, because once you start playing around with these sorts of pathways, you get significant mood changes and side effects of a lot of the therapies that are available. So this was actually quite an interesting slide. So the bottom line is, once we get from here to here, we're in really big trouble. And if we're looking at only lifestyle intervention when we've got established obesity, we're pushing very heavy loads uphill. So it's increasingly clear for long-term benefit, not for short-term improvement in reproductive outcomes, but long-term benefit, we're probably going to need pharmacotherapy. There's some good guidelines by the Endocrine Society on this. And we may even need surgery, but surgery is clearly not the answer when you've got really high percentage of the population. The bottom line is we need brave government, we need regulations like the ones that Chandrika talked about, improving interventions. It's now 20 countries in the world have tax restrictions on sugar-sweetened beverages with quite significant impact, and in Mexico the impact for the lowest socioeconomic group has been the most. It's fair to say that the industry pushes back very hard, but if you tax the foods that have the most effect, it works. People drink less or consume less of the foods that cause it. If you tax cigarettes, it works. If you put them in brand packaging and take away all of the advertising, it works. But it needs brave government. It costs almost no money, but needs brave government. So we need to address this with primary, secondary and tertiary prevention. Primary is the sorts of things we're talking about: healthy foods in schools, taxes, and then using that tax for prevention or for supplementing healthy food. So the bottom line is that if we want to say that obesity prevention needs to happen, then we need to do something about the 1 kilogram a year that goes on in young women. That 1 kilogram a year is about a positive balance of only about 14 kilocalories. So if you're having a small glass of juice a day, if you cut that down to half a glass, ideally don't have any juice, but just to give you an example, half a small glass of juice a day rather than the full glass, that is the only change that the population needs to make to prevent weight gain. So skip the biscuit at morning tea, don't have that lovely dessert we just had at lunchtime. It's a small change, but it's every day. And most people, when they know this, can do it. So the old adage here is that you educate the educated who can self-regulate. You incentivise those who struggle and you regulate those who cannot regulate themselves. That's the basic principle for every public health initiative that's been successful, whether it's speeding. So you educate people that they really shouldn't speed. You put speeding signs everywhere to try and incentivise them to do the right thing, and if they speed, they get a speeding fine. You do the same with seat belts, you do the same with smoking, but for some reason we do not do the same with obesity and food. So clearly we need to do something about this. And there's a lot of opportunity with public health approaches. I know that, for example, Bangladesh and Sri Lanka are really looking at some of these areas, and I would hope that countries with such high metabolic risk will do the same.